Hello everyone, this is Dr. Priyanka Chada and today I have a short presentation on acute respiratory failure. A day without humor is a day wasted. So here's a little humor on ICD-10 coding. Let's go on to the definition of acute respiratory failure. A more subjective definition here implies loss of the ability to ventilate adequately or to provide sufficient oxygen to the blood and systemic organs. Basically, our pulmonary system is no longer able to meet the metabolic demands of the body with respect to oxygenation of the blood and or carbon dioxide elimination. Let's go on to more objective definition of acute respiratory failure. A PO2 less than 60 mm mercury or SpO2 less than 91% on breathing room air indicates acute respiratory failure. Now mention is of breathing room air because this definition cannot be used for a patient who has chronic obstructive pulmonary disease and is on supplemental oxygen on a chronic basis. PCO2 more than 50 mm mercury and pH less than 7.35 would indicate acute respiratory failure as well, and this definition can be used more commonly for our patients who have chronic obstructive pulmonary disease and are on chronic oxygen. Another way is to look at the PF ratio, and if it's less than 300, it indicates acute respiratory failure. This ratio has been used for acute respiratory distress syndrome, and we'll look further that this can be used for qualifying acute respiratory distress syndrome into mild, moderate, and severe. For our patients who have COPD, another way of looking if there is acute respiratory failure, we can look at the PO2 decrease or PCO2 increase by 10 mm mercury from their baseline. And we all know that acute respiratory failure is almost always present if there is endotracheal intubation and mechanical ventilation or initiation of BiPAP or need of 40% or more of supplemental oxygen. Acute respiratory failure can be classified into hypoxemic, hypercapnic, or a combination of the two. Now this distinction is clinically important but not essential for correct coding. ICD-10 codes for acute respiratory failure, they are divided into whether if it's hypoxic or hypercapnic or a combination of two, if the patient had chronic respiratory failure or not, and in fact they have chronic respiratory failure, whether it's just chronic respiratory failure with hypoxia or if it's chronic respiratory failure with hypercapnia. There might be cases where a patient has acute and chronic respiratory failure. These would be patients with COPD on chronic oxygen therapy. Documentation is very important. It's essential to portray patient severity of illness. Documentation can influence quality scores, performance indicators, clinical outcome measures, and hospital revenue. So all providers should mention if there is any pre-existing or coexisting condition that could be contributing to patients' acute respiratory failure. And this could be chronic obstructive pulmonary disease, heart failure, pneumonia, sepsis, post-cardiac arrest, and chronic respiratory failure. And there are certain terms which actually do not help with correct code assignment. These terms have been used for even admitting diagnosis. Some of these terms are like dyspnea, hypoxia, respiratory insufficiency, or distress. A patient without chronic respiratory failure, we can look at their ABG, and if they have a PO2 of less than 60 mm on room air, or if they don't have an ABG, a pulse oximetry of less than 91% would indicate acute respiratory failure. For a patient with chronic respiratory failure, That implies chronic obstructive pulmonary disease patients or patients with other chronic lung diseases who are on chronic oxygen therapy. In those patients, a decrease by 10 mm mercury or more from baseline PO2 would indicate acute respiratory failure. For the PF ratio, as we discussed before, P indicates arterial PO2 and F indicates fraction of inspired oxygen. A PF ratio of less than 300 indicates acute respiratory failure. This ratio has been used for acute respiratory distress syndrome, where acute respiratory failure is called acute lung injury. We can classify ARDS into mild, moderate, or severe depending upon the PF ratio. A PF ratio less than 300 is mild ARDS and is equivalent to PO2 on room air of less than 60 mm mercury. So this is the ratio that we are looking at for our acute respiratory failure. If a ratio is less than 300, is mild ARDS. If you keep going further down, PF ratio less than 250 is moderate ARDS and is equivalent to PO2 on room air of less than 50. PF ratio less than 200 indicates severe ARDS and is equivalent to PO2 on room air of less than 40 mm mercury. PF ratio simply expresses relationship between inspired oxygen and arterial oxygen. In cases we don't have arterial PO2 from an ABG, we have a link here. If we click on that, all we need is the pulse oximetry and it will give us approximate arterial PO2. And we can use that arterial PO2 for our calculation purposes. Here's a table which shows a relationship between arterial PO2 and pulse oximetry. The number to remember is PO2 less than 60, which equates to pulse oximetry of 90%. So please keep these two numbers in your mind. Arterial PO2 less than 60, which is pulse oximetry of less than 90. We have ways of calculating or estimating FiO2. FiO2 depends upon how the supplemental oxygen is delivered, whether it's nasal cannula or a non-breather mask or a Venturi mask. For a Venturi mask, oxygen is delivered at a fixed FiO2, and the common ones are 24%, 28%, 31, 35, 40 and 50%. A non-breather mask is designed to deliver approximately 100% oxygen, while a nasal cannula has adjustable flow rate. FiO2 is somewhat variable and less reliable than a mask. So if we have to estimate FiO2 depending upon the oxygen flow rate, it shows here the values for a nasal cannula. So oxygen at 1 liters per minute approximately indicates FiO2 of 24%. A flow rate of 5 liters per minute indicates FiO2 of 40%. Nasopharyngeal catheter also has estimated FiO2 depending upon the oxygen flow. And here's a table for that. Another table for face mask for estimation of FiO2. Another table for face mask with reservoir. Depending upon the oxygen flow rate, we can estimate FiO2. Acute hypercapnic respiratory failure. This results from retention of carbon dioxide, which causes drop in the pH to less than 7.35. In our patients who have COPD, we'll see that the PCO2 would increase to more than 50 and the pH would drop to less than 7.35. Or in other cases, we can see that there is a 10 millimeter increase in baseline PCO2. Subjectively, there would be exacerbation of symptoms and patient would require more supplemental oxygen from the baseline. When we have an acute respiratory failure in a patient who has chronic respiratory failure, it should be documented as acute on chronic respiratory failure. Patients who have COPD and are on chronic oxygen should be classified as chronic respiratory failure patients. I had a case where patient was readmitted after a recent discharge. So in that case, I had a baseline pulse oximetry. At the time, patient was discharged and was doing well. And from this value, I interpreted baseline arterial PO2. And then the next time patient came in, I was able to calculate the PO2 from pulse oximetry, showing a drop in PO2 from his baseline, which was more than 10 millimeter mercury drop. And in that case, we were able to prove that the patient actually indeed had acute respiratory failure. There can be multiple causes of acute respiratory failure, but severe COPD is the most common one. Physicians easily establish a diagnosis by looking at the patient. Subjectively, they know that the patient is in acute respiratory failure. And also by looking at the ABG with PCO2 more than 50 and a pH less than 7.35. If the pH is more than 7.35, it would actually be chronic respiratory failure and not acute. Physicians might correctly identify it as respiratory acidosis, but unfortunately, it is a comorbid condition in contrast to acute respiratory failure, which has a status of major comorbid condition. So there is a difference between respiratory acidosis versus acute respiratory failure from the coding standpoint and from documentation standpoint, from severity standpoint. Let's have a brief look at chronic respiratory failure. It is characterized by a combination of elevated PCO2, normal pH, elevated bicarbonate, and hypoxemia. Elevated bicarbonate level on a BMP in a COPD patient gives us a clue. And it's quite common in patients who have severe COPD and are oxygen dependent. And it can also be seen in other lung conditions like cystic fibrosis and pulmonary fibrosis. Acute and chronic respiratory failure indicates an acute exacerbation or decompensation of chronic respiratory failure. In these patients, any degree of respiratory acidosis implies respiratory failure. They will have hypercapnia and acidosis. We learned before that pH is maintained normal in patients with chronic respiratory failure, but when they experience decompensation, the pH drops below 7.35. Diagnosis can also be made if patient has worsening of symptoms, increased requirement of supplemental oxygen, or greater hypoxemia. Let's take a brief look at post-procedural respiratory failure. If a diagnosis of respiratory failure following a surgery is identified as post-operative respiratory failure, it can actually adversely affect quality scores for the hospital and the surgeon. Other terms like respiratory failure due to surgery or complicating a surgery can also have profound regulatory and quality of care implications. Patient requires ventilator support for a short period post-operatively during surgical recovery period. Now in this case, respiratory failure should not be a diagnosis. Here we already know that patient would require ventilator support after the surgery. So if there is a mechanical ventilation that was expected or is usual following the type of surgery, we should not document acute respiratory failure as a diagnosis. Diagnosis identified should clarify if there is any relation to a pre-existing condition. And these pre-existing conditions could be COPD, CHF, chronic lung disease, including cystic fibrosis, pulmonary fibrosis, or any neuromuscular disease. In the post-op setting, acute respiratory failure should be written as acute respiratory failure in the post-op setting primarily due to pre-existing COPD or CHF, or if any other condition is deemed responsible for patient's respiratory failure. These are some of the examples that I took from CMS website. First example is a 78-year-old female readmitted to the ER with hypoxemia and hypercarbia. Her CPAP or BiPAP was inappropriately applied without oxygen. Now here's a red flag that the BiPAP was applied but without oxygen. Patient's chief complaint was shortness of breath, and the impression was that patient had respiratory distress, and she also had sarcoidosis and early CHF. The admitting physician documents it as diagnosis of panic attack, hypoxemia, hypercarbia, sleep disordered breathing with renal insufficiency and chronic anemia. The patient has a history of sarcoidosis, chronic anemia, and renal insufficiency. And the physician's discharge summary lists the final diagnosis as hypoxemia, dyspnea, anxiety, anemia, and shingles. Now, as we mentioned before, there are certain terms that do not help with the code, and here also we know that hypoxemia and dyspnea were used to list as final diagnosis. The auditor finds that there is no physician documentation of acute respiratory failure. In this case, auditor deleted respiratory failure code and changed the principal diagnosis to hypoxemia. This resulted in MSDRG change to other respiratory system diagnosis without major complication and comorbidity. So providers should keep in mind that the condition chiefly responsible for a patient's admission to the hospital should be sequenced as the principal diagnosis. And the other diagnoses identified should represent all CC and MCC present during the admission that can affect patient stay. Complications and comorbidities or major complications and comorbidities affect MSDRG assignment. Conditions present on admission versus hospital-acquired conditions also affect reimbursement. DRG. A brief history on that. In 1970s, Yale University developed diagnosis-related groups to describe all types of patient care. It assigns a numeric value to a hospital episode of care which serves to determine payment level of the hospital. Over time, DRG technology has evolved to include changes in healthcare delivery and advances in medicine. It also served hospital needs of data management, reimbursement, and comparability, besides benchmarking and other type of research. Some might wonder, what's the role for clinical documentation improvement? The goal is to improve quality of documentation to help ensure an accurate and complete reflection of patient's care, his or her comorbid conditions, and treatment which impact severity of illness and the risk of mortality. Documentation is valuable for depicting adherence to quality of care measures, liability protection, and useful data for research and education as well. As we discussed before, there are certain terms which do not help us in assigning proper code for the diagnosis. Take for example shortness of breath or hypoxia or dyspnea. These terms have been used multiple times. I have seen it being used on multiple occasions for assignment of diagnosis. But this in fact would be classified to respiratory signs and symptoms MSDRG. So remember, the diagnosis code that you document would affect hospital reimbursement. So imagine diagnosis code of shortness of breath versus diagnosis code of acute respiratory failure or exacerbation of chronic obstructive pulmonary disease. All these have different MSDRG and would imply different hospital reimbursement. If your diagnosis lists pneumonia, definitely patient's acuity is more complex and will have a different MSDRG. Listing of other comorbid conditions is important as well because it reflects the severity of illness of the patient and risk of mortality for him or her, even though MSDRG won't be affected. And we know that listing of secondary diagnosis and comorbid conditions definitely support use of more resources and justify higher reimbursement for hospitals. Let's take a look at hospital reimbursement for different diagnoses coded. First is COPD with secondary diagnosis of CHF. The MSDRG would be 192 without comorbid condition or major comorbid condition, and the hospital reimbursement would be the figure stated. Second is COPD with secondary diagnosis of systolic heart failure. Here the MSDRG would be 191 with comorbid condition and hospital reimbursement would be in 10,000. Next is diagnosis of COPD with secondary diagnosis of acute on chronic systolic heart failure. You might have noticed that the specificity of the diagnosis keeps on improving. Initially, we saw the COPD with secondary diagnosis of heart failure. The second example had COPD with secondary diagnosis of systolic heart failure. And now this third example is COPD with secondary diagnosis of acute on chronic systolic heart failure. Next, respiratory failure and pulmonary edema. The MSDRG in this case would be 189 with the hospital reimbursement of $11,695. At the end now, let's again look at documentation points which help us make diagnosis of acute respiratory failure. Number 1 is persistent dyspnea following short-acting beta agonist for more than or up to 3 doses. Oxygen saturation less than 92% or arterial PO2 less than 60 mm mercury. And continued deterioration despite 24-hour outpatient treatment. These are also more on lines of justifying patient's admission to the hospital rather than treating patient as an outpatient. And other subjective findings like mental status changes and blood sugar of more than 350 mg per deciliter. And at the end, here are the links for CMS website which help us put in correct diagnosis code depending upon the new guidelines for ICD-10. Thank you everyone for going through the presentation.